I do want women to know that there is an alternative to suppressing their bodies with hormones, that they can see their body as a good and they can live in that body holistically.
Totally. Oh my gosh. It's amazing.
Join co-hosts Jamie Rocci and Teresa Kenny as they educate women about the beauty of the feminine design and empower women to take charge of their health.
They're going to be so amazing. You're going to be so empowered by understanding your feminine genius and your hormone genius. I don't think I could live my whole life knowing this and not sharing it with anyone.
Welcome to the Hormone Genius podcast. We have an incredible interview today. I am so excited to have Dr. Christopher Stroud with us. And Dr. Chris is going to give us his, details on who he is. But I just want to start with a question because he has been in the world of women's health for a very long time. Not to call you old, Dr. Stroud, but you've been in it a long time. I mean, I have too. But my first question, I was thinking about this morning, was what do you think like the greatest advances in women's health have been, particularly in this area of more restorative or holistic or NAPRO women's health? And then also, where do you think we have still the greatest gains to make in women's health, or where are we stuck the most still in 2025?
Yeah, that's an interesting way to start. I mean, I bet this surprises you. It even surprises me to say it, but I think one of the greatest advances in women's health is what we're doing right here, social media. Because there's plenty of evils of social media, and we could list them quickly, I'm sure. But one of the incredible positives about social media is it gives people a platform to share their wisdom, their ideas, their opinions that simply did not exist when I was in training. So, and if we think about hormones, and if we think specifically about maybe the nurse's health study and the dogma that evolved when I was fresh out of training in the late 80s, early 90s, about hormones cause breast cancer, period. End of discussion, don't talk about it anymore. If a physician recommended hormone replacement therapy to a woman in need, you were looked at as though you had leprosy. Who in their right mind would say that? What's wonderful about social media now is reputable, well-read, intelligent people can express problems with the nurse's health study and things like that, and have an avenue to get that message out that simply did not exist, pre 2000. I'm dating myself that I don't remember, but I think that indirectly has been one of the greatest advances because the information was there, but there was simply no way outside of the traditional channels to get that information out, and you would be ostracized from the journals and the conferences if you tried to do that. So that has been a terrific advance. I think the entire concept of bioidentical hormone replacement or hormone optimization has been a huge advancement. And there are plenty of influencers who will say there's no such thing, and they're just dead wrong. But the idea that taking hormones derived from horses' urine is not necessarily natural, but taking hormones that are derived from plant-based findings or derivations, that is different. And we can look at the biochemical structure, and now we have the ability for, not a PhD in biochemistry to look at the biochemical structure of something and understand it. I think that's a tremendous advance, and that's just a couple of examples.
Yeah, such an important thing to talk about is the vehicle and the benefit of using social media to share information, but then also sometimes the downfall or the downside of misinformation. So, in regards to hormone replacement therapy, and we have you on and we're going to cover a lot, specifically PCOS, wedge resection. I mean, we're like salivating at the mouth, Dr. Stroud, to talk to you more about that. Since you mentioned hormone replacement therapy, no matter how many times a woman hears it's okay, or let's think outside this box of thinking that it's wrong, what kind of advice would you give to a woman who has breast cancer in her family?
Oh, yeah.
Estrogen-induced breast cancer. What kind of advice would you give her?
Well, I would back up first because I think you passively or passingly said something really important. Estrogen-induced breast cancer. I think it would be important to clarify this estrogen receptor positive or negative phenomenon in breast cancer. And I hear this regularly. So a
Mhm.
woman says, my mother had breast cancer. It was caused by estrogen. I say, whoa, wait. What do you mean? Well, it was estrogen receptor positive. And then we have to pause and say, I think you're the victim of some misinformation. Estrogen receptor positive breast cancer is a good thing. That's a positive thing because that means that your breast cancer still resembled breast tissue enough that it had estrogen receptors on it. Estrogen receptor negative breast cancer is a big deal because that means that cancer is so far removed from natural breast tissue. The way that we say that is undifferentiated, that it's not going to respond to anti-estrogen therapy. And so that always takes people a few minutes to kind of process that because they hear estrogen receptor positive breast cancer. That means estrogen caused it. It does not mean that at all. Just the opposite. It means if we rob it of estrogen in certain therapies that do that, it will very likely respond. But estrogen, progesterone, or they sometimes will say triple negative breast cancer, that's a really bad finding diagnostically. Does that make sense?
Yes, it does. And it's just interesting because I think as we share this information with women, even in the women's health world, nurses, doctors, it's just like there's a lag in understanding or a disbelief, that hormone replacement therapy isn't, the
Yeah.
Goliath that we think it is. So
And our
yeah.
vocabulary is so confusing. We do it to
Yeah.
ourselves.
Yeah, that's right. That's right. What kind of advice here? I'm just
Yeah,
going
to
to
that
kind of do
patient.
one follow-up question. What kind of advice would you give then to medical professionals who serve women in this space? How can they
Yeah.
be informed? How can they get the right information?
Yeah, so you just have to understand the physiology of well-differentiated versus undifferentiated breast cancer. And like one of the positives of social media is it's easy to find. One of the positives of AI is it's easy to find. You can go into Chat GPT or whatever AI product you like and say, please summarize all published literature on the differences between estrogen positive and estrogen negative receptor breast cancer. And you'll have PhD level work there in front of you in less than 30 seconds. Now, AI's got some limitations and the studious user needs to understand those. But if I go back to your original question, because it sort of fits with your follow-up too, how do I advise that woman? I say, we need to know more about your mother's breast cancer. Was your mother BRCA tested? Did she have the inheritable and the ability to pass on a gene mutation that changes you, the woman in front of me, that changes maybe your breast cancer risk profile? That's a big deal and important to understand. If the mom was tested and she's negative for BRCA, she can't pass on what she doesn't have. If you don't know the mother's status, or maybe she's no longer living, then that person in front of me should probably be tested. If her mother's breast cancer was before the age of 50, especially. So there's lots of follow-up individual pieces. But in general, if a mother had estrogen positive breast cancer, that's no reason that the woman in front of me can't think of herself as a candidate for estrogen-based hormone optimization. Um, I hope that makes sense and helps.
It's amazing, Dr. Stroud, just how words matter so much
Oh
and
gosh.
how we push a narrative for years. And it is so hard to change the narrative quickly, right? So it takes many years for us to now retrain the mind and the brain and the intellect and all of it to be able to see like, okay, I have no fear now. And that's really what it is. I mean, everything is based in fear and anxiety of what is this going to do? And I always tell my patients, I will never want you to take estrogen or a hormone treatment in a place in the back of your head that says, I'm scared of this.
Mm,
Like it makes no sense to me until you feel fully at peace that
yeah.
you understand, the risks and the benefits of something and you have a peace about it. I will never prescribe it to you in a place of anxiety because that doesn't make sense, right? It doesn't make
Mhm.
sense to fear a treatment that you're taking.
Yeah, well
Just
point. Yeah.
a good example of this, I had a woman who is suffering with vaginal atrophy, painful intercourse. She's 60. And I tried to explain, as I was going to prescribe her vaginal estrogen, that vaginal estrogen is the safest. Like, I think we can all get behind vaginal estrogen at this point. You know, everybody has access to that, even breast cancer patients, even those who have had breast cancer. But I tell you what gets it every time is that package insert. Mm-hmm. Even if I reassure them, they go home, and if they're a smart person that just wants to read what the package insert says, it's going to tell them all these horrible things about vaginal estrogen that are completely not true. And, you know, the FDA is working to change that, but everything is slow. But it's frustrating because you're like, why would they put that information? And it's completely not true. And it scares people. Again, it induces this fear. And, you know, and patients suffer because of it, right?
And, you know, the reality is the person you're talking to, in all likelihood, is taking 2 or 3 other medications, and they have never opened that package insert. But they open it on estrogen because of something they heard. You know, I like to say that package insert is written by the government for the government, not for anyone else. But, you know, I think there's a really important concept that's difficult to wrap your brain around, and it's this idea of relative risk. So just like we're doing here, we're saying, let's just say I'm worried about the risk of taking estrogen and getting breast cancer. But the discussion has to be much broader than that, because there's always the risk of not doing something. So, you know, a patient is going to drive to see me today, God willing, and she jumped in her car and got on the interstate and not once thought about the very real probability she'd be killed in a car accident coming to see me. Yet, if you ask an actuary, there's a very real probability that she would die in a car accident. It's raining today, so it's even, you know, it's a greater probability. But she jumped in the car and didn't think about it. That's because subconsciously even, she was doing this complicated risk-benefit analysis. Yes, there's a risk of dying, but I think the risk of getting the information outweighs that small risk of dying. Well, we have to always think about medical decisions in the same way. It's not only the risk of what you're considering to do, it's also the risk of what you're considering not to do. So when we start trying to unpack that complicated estrogen question, then it becomes very clear. Well, what about the risk of dementia if you don't take it? What about the risk of colon cancer if you don't take it? What about what they call all-cause mortality? Everything that kills you goes down if you're taking estrogen. So to focus solely on breast cancer is very short-sighted. Now, it's our fault in healthcare. We've done that to people. But I think, you know, people like us are trying to undo that so that patients can make much more informed and balanced decisions that are right for them where they are. But every decision is not right for every patient. But we can't neglect the other side of that risk equation.
It's a great answer. And I have that same conversation with patients every day. I mean, I really do. I know a lot of us out there do, but it's hopeful. It's really hopeful that, you know, this information is getting out. And again, it's benefiting the health and the lifespan of our patients. You know, like for 25 years, women have not had correct information, and some have suffered and maybe died because of that, you know. So really to be able to put that in a larger perspective of relative risk, like you said, and really focus on the whole picture, that is the important thing. So all of you listening, I want you to pause for a moment and think about that for your own health when you get to the point you're making a decision like hormone replacement therapy for perimenopause to menopause.
And it's an important concept for everything in healthcare. You know, so your family physician recommends taking this medication for your blood pressure. You know, are there risks of taking medication? Yes, there always are. What about the risk of not taking it? What about the risk of you being on dialysis when you're 60? You know, all of those things have to be taken into account to make a balanced, informed decision that you're comfortable with. But it's so important in medicine, and it gets dropped in the hurried, fast-paced interactions that happen in the office, unfortunately.
Jamie, I know, wants to talk about PCOS and the wedge resection. I do too. For some reason, Dr. Stroud, I don't know if you feel this way about yourself. Like, I feel like you got to be known as the wedge resection doctor.
Oh,
and
I've
I'm
been
not
called
sure.
a lot of things, but that's the first time I've been called that.
I don't know. It might have been my own like doing. Maybe it was just the one talk I went to or saw that you did, and you were so good about talking about the wedge resection and its benefits for PCOS. So let's shift backwards, I guess, in terms of the woman, in terms of her fertility. And I do want to focus, we've talked a lot about PCOS on this podcast, Dr. Stroud, but we haven't probably talked as much about infertility and PCOS and really the treatment options. And of course, most people kind of know there might be some medications that you can take for PCOS, and that might help you ovulate right when you have polycystic ovarian syndrome. But people are probably very unfamiliar with a surgical approach to PCOS. And I know there's a big historical perspective regarding the treatment of PCOS. And so I'd love for you to just share kind of that and just where we're at, with how we treat PCOS potentially surgically.
Oh, good. It's a wonderful topic. As you mentioned, it's very old. So 1929, Doctors Stein and Leventhal, because PCOS, when I was in school, was called Stein-Leventhal syndrome, and it later became PCOS. But these two physicians somehow recognized, with the technology available, that this group of women had this similar collection of symptoms, whether it be high blood pressure, weight gain, unwanted hair in places, especially male pattern hair, acne, all sorts of things made this collection of symptoms in women. And how they got the idea to slice their ovaries open, I don't know. I mean, and how they convinced the first patient to do that is even more fascinating. But be that as it may, they learned that if you removed a wedge, think of a pie and cutting a piece of pie out of a circle, that those women suddenly started to exhibit changes in their previous symptoms. Their blood pressure came down, their cholesterol came down, their weight gain slowed. Their symptoms of male hormone overdose, acne, weight gain, hair growth, those things started to get better. So they began doing this wedge resection. And then it was a very morbid surgery, I would say, because it required what we call a laparotomy, an old-fashioned, long, midline skin incision. Not very popular, but yet some people would be desperate enough to have that done, but they got better. So that kind of traveled on through the years, admittedly a positive procedure, but not something people were excited about having because of it requiring an old-fashioned big surgery with extended recovery and those things. Also, with the techniques used at the time, a lot of adhesion risk. And if you Google or go on YouTube right this minute, you're going to find wedge resection causes adhesions and damages the tubes. It's very old, but that's what they're going to find. So it was what it was for a long time. Then laparoscopy came into be really when I was in residency training. I'm embarrassed to say, in the late 80s, early 90s, you could do laparoscopy, put a camera in someone's belly and do things. Take out their appendix was one of the early things. Take out their gallbladder. Treat an ectopic pregnancy was a very big deal in women's health through this camera laparoscope. At about the same time, CO2 laser was developed. And so people started doing laser things through the laparoscope. And that's where this procedure that you'll read about if you research this called ovarian drilling came from. They thought, well, we can't do something as advanced as cut a wedge out of the ovary with laparoscopy, but we could probably accomplish the same thing. That is, destroy part of the center of the ovary relative to the periphery of the ovary. And maybe we would get the same effect. And so they started drilling holes in women's ovaries with a laser. And lo and behold, they got some of the similar effects from wedge resections. Some big problems: a laser would burn the surface. That could create adhesions. That very delicate little fallopian tube is millimeters away from where you would be burning the surface of the ovary. So there was a probability that you could damage that tube. If that happened on both sides, that could be game over for the woman's fertility. But ovarian drilling, much to my disagreement, is still done today. Now, others, like Dr. Thomas Hilgers at the Omaha, in Omaha at the Creighton Institute, started doing ovarian wedge resections by making a mini laparotomy, a very small incision, and then using microsurgical techniques that he really standardized and I'm probably not comfortable saying invented, but he optimized to sew the ovary back together again and to do several other techniques to prevent adhesions. So Dr. Hilgers and at the Omaha Institute was saying, we can do wedge resections without getting all the problems that happened in the old days. And that was very popular, especially in the Creighton NAPRO world. Well, then the big game changer was really in the early 2000s, 2005, 2006, the advent of the Da Vinci robot. And robotic surgery for women's health and for men's health and urology as well has been an absolute disruptive technology. So that allowed us to do things via the laparoscope that before that could only be done through an incision. And in our world, the biggest thing was a robotic assisted ovarian wedge resection. So we could do the exact same procedure that you used to have to make an incision for, but now we could do it through little Band-Aid incisions with a Da Vinci robot. We could do the microsurgical repair techniques that Dr. Hilders promoted and get those same results without having to do a big incision. So really in our world, mine and your world, the NAPRO world, it exploded as a technology available to women that before really didn't have great options. So it can be, and I hate to use the phrase, but it can be life-changing for women that otherwise would not have that available to them. So the ovarian wedge resection is admittedly a big surgery. I don't want to understate that at all. But for properly selected patients, it's as close to a cure for PCOS that anyone is ever going to experience. And we cut a wedge out of both ovaries. There's a lot of good videos out. I think there's some on the Creighton website. On my website, myfmcc.com, we've got a wedge resection example. But it's an amazing procedure that for the right patient and the right time in her journey, it can really be life restoring. I could go on for hours. I know you don't want me to, so I better stop and let you ask me things.
Well, you mentioned, the properly selected patient, the right woman in the right season. What is the right woman in the right season? How would you select a woman who would really benefit, as opposed to, of course, we know lifestyle plays into, metabolic disorders and PCOS included in that circle. So I'm wondering, how do you know who would be the right type of patient for this?
Yeah, that's where, despite some of the feelings today in medicine that everything is AI and technology, that's still part of the art of medicine, which is a beautiful thing and maybe a scary thing. But understanding anyone can learn to do a procedure, doing it on the proper patient at the proper time, that really is more of the art of medicine. And different naprosurgeons might speak to that differently to some degree or another, and might actually be saying the same thing with a different perspective. But I tend to think of it in a couple of ways. So a very common way that wedge resection comes up in PCOS is women that are on a fertility journey. So with PCOS, I like to say we treat the problem of the moment with an eye to the future. So today I may see a 16-year-old girl who is struggling. She's having insanely irregular periods or no periods at all. She's gaining weight. She has acne. She's so unhappy. She just wants to fit in and be like everybody else. She doesn't care about diabetes. She could care less about her cholesterol. She's not even thinking about ovulation. So I'm going to help her today, but I'm thinking soon she's going to be interested in these other things. But on the fertility journey, the woman is thinking about ovulation, that part of PCOS. So we're likely going to use medications to try to get her to ovulate and ovulate in a healthy way, because a big part of PCOS is the absence of healthy ovulation. That's often going to require medication, dose changes, sometimes multiple medications, but we may get to a decision point where they're just not working. And so that decision point is, do we go one way and use the very powerful, unfortunately very expensive medications that are often used in the IVF cycles? Those are called the injectable gonadotropins, like Follistim and Gonal-F and some of those, to try to really powerfully stimulate the PCOS ovary? Or is it time to think about a wedge resection? So one opportunity for wedge is when traditional things are not working. Could we get ovulation better with a wedge resection? Another avenue that could lead to a wedge resection is maybe in the patient who is not even trying to achieve pregnancy, but she is frustrated with all of the other symptoms of PCOS. Ovulation maybe isn't first on her list of things, but the other stuff is just not getting it for her. And she's frustrated and she thinks, I think wedge resection could be right for me. And it could be in that setting. And then the third category, I guess I would mention, which is uncommon, but not unheard of, is the couple that wants to use NFP to avoid pregnancy. They're serious about not becoming pregnant, but they're equally serious about using ethical and healthy ways to do that, and they want to use NFP. But PCOS has made it such that the PCOS patient trying to use NFP is another way to say long-term abstinence. And they recognize the problems with that. But I've had several patients say, I want you to do a wedge resection on me so I look like everybody else, so I can use NFP like everybody else to avoid pregnancy. So if we have any Protestant viewers, they're probably laughing at this point because that sounds like the dumbest thing they've ever heard of. But a lot of our Catholic listeners are probably thinking, oh, I get it. That makes perfect sense to me. But admittedly, that third category is the minority. But I think those are three common pathways that would lead us to sit down to have an ovarian wedge resection surgery.
Thank you. I'm going to interrupt our show here just for a moment to shout out to our podcast partners, We Heart Nutrition. We Heart Nutrition is an incredible, amazing pro-family organization that provides wholesome and bioavailable vitamins and nutrients to the body. So if you visit weheartnutrition.com, you will get 20% off of your order by typing in GENIUS, which is GENIUS. It's We Heart Nutrition and code GENIUS for 20% off your first order. Had to say that, to bring that in, Dr. Stroud. So thank you. One last question here as we tie up this topic on the PCOS patient and wedge resection. Okay, so when we think about the woman who struggles with PCOS, and you're identifying, and you did a great job of breaking down these three types of women who could benefit, what is the likelihood that they slip into an old pattern of potentially their lifestyle, sedentary eating, let's say, that then brings them back into this PCOS state? Do you see patients reverting back to PCOS after wedge resection, or do you see like, no, actually, this it helps a lot, even with the choices they're making and all? Because we know that we're a cocktail of things. Our hormones are always rolling, and it's not just an isolated thing that causes an issue.
Sure.
So what would you see in that case?
I've seen a spectrum. As you say, we're a cocktail. I like to say we're complicated animals. But one of the magical things, and I don't know that we want to get into GLP-1s and 2s, or whether it's bariatric surgery, is it leads to, in many, many cases, motivation and enthusiasm that simply did not exist before that. So you take the woman who is gaining weight sitting next to her husband's food, and she goes on a diet with her office mate, and the office mate loses 30 pounds and she gains 5. That's one of the reasons depression is such a big part of PCOS. So she's not excited. She has zero enthusiasm, and she has negative motivation. We do a wedge resection. She suddenly stops gaining weight. And over the course of a year, perhaps, she begins actually losing weight, maybe for the first time in her adult life since adolescence. That can unleash an enthusiasm and an optimism and a motivation that changes everything. And then suddenly, great food choices and great lifestyle choices become easy, whereas before they were a source of pain and suffering. I have certainly seen that many, many, many times over. I've also seen other people that, just like with bariatric surgery or just like with GLP-1s and 2s, they get excited, life looks good, and over the course of time, maybe that's 18 months, maybe that's 36 months or longer, they can slip back and revert. And the question, I think, always becomes, did your wedge resection fail you, or did you perhaps fail your wedge resection, or both? And Dr. Hildreth has a series where he talked about repeat wedge resections. It is not common, and it's wrought with some difficult conversations, but it's not off the table in some cases.
Okay, well, I can't say enough. I've seen a ton of success with the wedge resection. I'm a nurse practitioner, so I don't do the procedure, Dr. Stroud, but I have watched many patients. And I think what's so exciting is it's like the chart. If we see the Creighton model chart, I love this, like, again, and this is why we love charting so much. It's like a window into the body, right? And you take someone with like only having periods every 3 to 6 months, let's say, and you do a wedge resection, and all of a sudden you have this patient having their cycle and healthy ovulation every 30 days, it's a miracle. It's a miracle. And it really is something where we need to do more research. And I know you would agree with that. Like, the problem is like, if people look this up, they're going to be like, well, I don't see a bunch of regular doctors out there doing this. And it's unfortunate.
That's because they're not. Yeah, they're not.
It's so unfortunate.
In fact, they're opposed to it. They're not only not doing it, they're in direct opposition to doing it out of a position of ignorance, unfortunately. But I'm with you 1,000%. I get those phone calls, and the woman is squealing on the phone in excitement, simply because she got to put a white baby sticker on her chart for the first time, maybe in 3 years of charting, instead of a sea of green stickers. She'll say, I have a drawer full of white stickers that I've never been able to use, and suddenly I have mucus. And then a month or so later, she'll call me and say, you're not going to believe this. I had a period on my own. Mm-hmm. I didn't have to take progesterone to induce a period. Suddenly she's feeling like she felt like she was supposed to feel at 14 and never did. But you're exactly right. It is a powerful tool. Just an interesting sort of tidbit for you about other physicians. When I started doing wedge resections, after sort of being converted, you might say, by Dr. Hilgers, I got attacked in my local hospital for it. I doubt any of those people are listening to this podcast, but some of them are still around. Mm-hmm. But I got attacked for it. And I got so attacked by the medical staff structure and the peer review structure that they decided they had to do 100% chart review for every one of my wedge resections that I did over the course of 2 years. And so I said to the system, okay, well, if you have to do that, let's send them to the Creighton Institute. They're the experts on wedge resections, and see what they say. They said, oh, no. We're going to send them to an IVF doc to review your wedge resections. So I thought, well, that's the end of me. I'm finished. They won. The devil has won. I'm done. I'm cooked. But I guess God had a different plan, because the reviewer from the reproductive endocrinologist, anonymous reviewer, said, okay, and those patients who have a religious opposition to IVF, an ovarian wedge resection is an acceptable alternative. Reading that letter, I wish I'd saved it and sort of plastered it on the wall. But it was the most affirmation, a general OBGYN has probably ever received. But it just goes to show how the opposition to this technology is tremendous.
And let's just state, because I don't think we did, it is a powerful treatment for getting pregnant, right?
Man.
Like I remember there was a particular fellow that came through Pope Paul VI Institute who did kind of just a study an in-house study of all the wedge resections that had been done in the last 2 years. He went back, and it was an 80% success rate for pregnancy, and that's not published, but still it was impressive. Because if you treat an underlying root problem at its core, right? And we know this resets the ovary, it resets the hormones, it resets the body in so many ways. It literally allows the woman to do what her body was meant to do, right? And then she just gets pregnant. Like, it's just a miracle in that sense. And so I wish I could say to all you women out there, just go call your doctor and ask for this. Now, that's not how this is going to work.
It's not going to go well.
Yeah, it's not going to go well, right? But you at least know there's people out there like Dr. Stroud. I mean, they are available. There are, physicians, and you can always reach out to us. We will try to put you in touch with doctors who know about this procedure. Mm-hmm. I do want to change directions, because I want, you mentioned ignorance, and it's a strong word, but I would call myself ignorant in many areas of life. It's just a part of it. Once we know, we can do better. Jamie and I also talk about that a lot, but let's talk about progesterone in relationship to supporting pregnancy.
Ooh.
And why there's such a pushback from physicians on using that support. And I know it's something that you wildly, believe in and help women with, progesterone support. I know many women out there feel attacked in a sense from their doctors, or not supported, and have to beg on their knees in a sense to get this support to what they believe is something that could help prevent miscarriage in pregnancy. So just give us your perspective on that, and kind of like, how would you approach that from, like, if I had to talk to a doctor or a colleague that disagreed with me, what can you kind of give as your expert testimony to that?
Yeah, my favorite one, especially when I'm talking to other obstetricians, My favorite one is to say, if you have an IVF patient, a patient of yours goes to a reproductive endocrinologist and has IVF, what do they do to that patient 5 minutes after she gets a positive pregnancy test? Oh, you don't know? They give her high dose of intramuscular progesterone injections, much, much higher than we give in the Creighton world. I mean, they flood her with progesterone because of progesterone's ability to sustain an early pregnancy, or the corollary, because of the danger of inadequate progesterone not sustaining an early pregnancy. And then often I'll get the response, well, those guys in the IVF world, they do strange things. And besides, those are prize pregnancies. To which I love to say, well, I don't know about your patients, but my patients think their pregnancies are prize pregnancies as well. That usually ends the conversation. And then they give very high dose progesterone in IVF until the patient's about 12 to 14 weeks along. And the truth is they only stop it then because that's when they hand them over to their general OBGYN who's going to stop the progesterone. But it's sort of indirect evidence of the absolute importance of progesterone in early pregnancy. And then if somebody wants to talk a little more academically about it, then I refer to the work at the Pope Paul VI Institute, where they're in the unique position to have decades of progesterone data on all sorts of pregnant women. And you know this well, but I'll just tell the story. So they looked at progesterone every 2 weeks for decades in pregnant women, and then took that database and said, hey, show me the progesterone numbers for the most boring, normal pregnant women ever. Women that had no problems, breezed through pregnancy, no growth problems, no preeclampsia, no placental abruption, no stillbirth, nothing. They just had a boring, easy, normal pregnancy. What did their progesterone numbers look like at every 2 weeks in the pregnancy? And that created a line, right? But now it's population, so there are standard deviations above that line and below that line. But this is the normal pregnancy population's numbers of progesterone. Well, then the corollary, how about you show me the other women? Show me the women who had growth problems. Show me the women who had placental abruption or stillbirth or preeclampsia. Well, what do you know? Their progesterone in every single case was lower than the general population who had normal pregnancies. So the philosophy became, well, if we want to look like that group, perhaps we should try to make their progesterone look like that group. And that's where the incredible protocol from the Institute for Progesterone Replacement comes. And we follow it. We follow it blindly. And sadly, we're following it often on women who've had 3 or 4 losses and no one would help them. They come to see us, we diagnose them with low progesterone, we supplement with bioidentical progesterone, and they go on to have a normal pregnancy, which is a beautiful thing, but it reminds them, I probably lost other children because I didn't have progesterone. So it's a sad thing at the same time. But I'll have that fight with an OB any day of the week, 24 hours a day, because we're on the side of life and we're going to win.
Yeah.
It's probably important to point out to listeners that in the early days of pregnancy, let's say in those early weeks of pregnancy, progesterone is low. We don't know in that moment, in the storm, I'd like to say, we don't know if the progesterone is low because it's an abnormal pregnancy that is destined to fail, or is it a perfectly healthy, normal pregnancy, but the ovary, the corpus luteum within the ovary, is not making enough progesterone. So we're going to err on the side of life because we'll save that second group. We're not going to save that first group, but we don't know. So because we want to err on the side of life, we're going to throw progesterone at you anyway and hope that you're in that second group. Our detractors will say, you're just prolonging the inevitable. In other words, if a pregnancy is destined to fail and I give you high dose progesterone, you're still going to have a miscarriage. It's just going to be a few days or weeks later. The reality is it's not going to be much later, but it could delay that a bit. But if we're right, we'll save a child. So I'll take that risk. And my patients agree wholeheartedly they'll take that risk as well.
Yeah. It's like a probably will help, can't hurt thing.
Precisely.
It's so frustrating, Dr. Stroud. I can speak just from my own experience. When I was charting my cycle early in my motherhood, we had just had one child. She just turned 1. I remember it was December. It was around Christmas. And found out that I was pregnant, very excited, but knew that my luteal phase was short, like the 9-10 day
Yeah.
Okay. And because it was over Christmas, it was difficult to get into a doctor and talk to them. And I was an intern as a fertility care practitioner. So I knew enough to advocate, but I didn't know enough to really hold strong. So I went to the midwife who delivered my first child, and I was very concerned. And I said, I really need some progesterone. Please, would you just prescribe me some progesterone just to be safe because of my charting pattern? And she said, oh no, Jamie, you trust your body, right? You're natural. You trust your body, right? You don't need progesterone. Just trust. And I said, no, could you please, I insist, please write me a prescription. I really need progesterone. And even as a practitioner, granted, I was an intern, I knew more than the average woman. And she still had a power over me. I allowed her to have this power over me that only later did I just look back and think, oh, if only, because guess what? I did miscarry.
Oh, I'm sorry.
And it was a very frustrating scenario. And what she could have easily done, it's not hard. I think that's the difficult part for me. It's not like we're asking the doctor to do something crazy or like this really unfounded thing that might actually harm us terribly. You know, I think that's what aggravates me so much, Dr. Stroud, is it's not harmful and it's easy enough. And why is it a pride thing? You know, why is it that doctors, midwives, whoever have such a hard time doing this for us? So frustrating.
It is odd, and I've thought about this a lot. And I've been asked this question so many times. And I mean, the truth is, I don't have a good answer, but it there's a there's a cultural issue in medicine, whether you're a physician provider or a non-physician provider. And I think, now this is just as my own brain, and we don't want to be outside of the circle, right? We don't want to fail the test. We don't want to get in trouble. We don't want to be that group. We want to be this group, the group that's okay and doing all the right stuff. We don't want to be labeled as a bad provider. You gave the wrong antibiotic, you gave the wrong blood pressure medicine, you harmed someone. So we have this culture that we're victimized by to some degree that says if the system says it's no good, then I'm not going to do it because I don't want to be that guy. I don't want to be that outlier. And it can be very difficult to break out. When I went under that 2-year chart review, I was a wreck. I mean, I was really a wreck. And I've lost track of time. I mean, I was probably 50 years old at the time and still incredibly susceptible to that. Now, yeah, in another decade past, I could care less what they think. But it took a long time for me to get to that senior position. And so I think most OB providers say, look, the system says there's no proof that it helps, so I can't do it, or I'll be an outlier. Whether they would admit to that or not, I really believe that's what it is. I don't think they're ill-intentioned. I don't think they're evil people that don't care about your pregnancy, but that culture is overriding their ability to say, well, let's just do it. It can't cause you any harm. Now, a happy side to that is, I'll bet all NAPRO providers like me have robust remote progesterone programs. I mean, I'll bet today my practice is managing 1,000 patients who all we're doing is managing their progesterone in pregnancy. We do a telemedicine referral. They say, my OB won't give me any progesterone, will you? And we, do an agreement that we'll manage their progesterone, and they tell their OB, I got this crazy, wacky doctor in Indiana that's managing my progesterone. You're not responsible. And that's what the doc wants to hear. You're not responsible.
Right.
And so we'll manage their progesterone, and it works very well. And I know many, many NAPRO docs do the same thing. So, listeners, if you can't get any leeway there, find somebody that will manage it remotely. There are plenty of people that will.
That's so good to hear. I know patients out there are going to be, listening and excited. It also makes me think, this is so random, Dr. Stroud, but there is this Instagram reel going around, and it's a woman in menopause, and she calls herself in the perimenopause club, but she said, she's like, this is the we do not care anymore club. There is a point in life, right? You get to, you're so afraid of authority and you want to do all the rules, and you want to be a good student and all the things. I think you're spot on with all that, but you get to the point where you're like, yeah, we just don't care anymore. Life, you see your own mortality in front of you, right? We don't have many years ahead, and we want to do good work and help people. And you're like, forget it. like I'm doing this, And so I love that. And I think women out there who are 50 and beyond like me were like, yeah, we just don't care anymore. We're just going to speak truth in love. And for those who hear it and want to come along and join in, let's do it. We can do this together.
Yeah. When you say the perimenopausal club, it makes me think we have a big hormone optimization division, you might say, in our practice. And it's full of those women that you just described. They're saying, my life is a disaster. I don't feel well. I don't think well. I'm not doing well at work. I'm not doing well with my kids or grandkids. Intimacy with my partner is a thing of the past. I feel old. Don't talk to me about some theoretical risk of something that's going to shorten my life later, because I don't have a life right now, and I want it back. And I don't remember seeing so many people that were that bold 20 years ago when I was earlier in practice, but now they're everywhere. And maybe that's a positive effect of social media. I hope so.
I think it is. I agree. Jamie, I think as we wrap up here, I will let you ask the last question, and then we'll let Dr. Stroud really just tell us all of whoever he is. We haven't gotten to that part. Like, who the heck are you, Dr. Stroud? We didn't do that part. So we'll, at the very end, let you give all your details. But Jamie, go ahead and ask the last question.
All right. Dr. Stroud, what do you wish every woman knew about her hormone genius?
Well, I wish more of them listened to your podcast. I think, and I'm not just sucking up to the host, but I do think your work is unique, and you come at it from a unique perspective. And there are others. We're not the only people saying these things, and there's plenty of room for people to say these things. But I wish more women would search out and find credible information like that you share. I don't even want to say promote, because that sounds wrong. You're just sharing good information. So I wish everyone knew that. I wish all women knew that they very likely do not fit into a nice, tidy hormone box. So, I'll see a woman who's maybe 38 and she's struggling with the absence of libido. And the lab says her testosterone is normal. And she says, yeah, but this started after my last child, and it's not me, and I hate it. Well, I can't help you. The lab says your testosterone is normal. Well, you don't fit in a box, perhaps. Everyone doesn't. And if anyone doesn't, I would say it's a woman with hormonal related complaints. Just because you don't fit nicely into someone's diagnostic box doesn't mean it's not hormones. Hormones are complicated, and the same problem doesn't present itself the same way in all women. And just because an influencer tells you that if you ate more garlic, you'd feel better, that doesn't mean you will. It may, in fact, be your hormones. And if you're not getting the answers that are helping you, look more. Vote with your feet. Leave that provider, go find another provider. If anything positive came out of COVID, I think it was a realization that we can do remote medicine really, really well. I would say half of my surgery consultations today come from remote visits. And that didn't exist pre-COVID. And so now a woman has the ability to say, I don't like what I'm getting from my provider. I'll go cross country. I'll go out of the country. I'm going to find something, and somebody will help me. And if you're willing to just have a thirst and a drive to do that, you'll find the right person that can get you the right answers. But don't try to put yourself in a box and be frustrated that you don't fit there, because all women are not the same, and all hormones are not the same. I'll leave it at that.
Well, Dr. Stroud, I sure hope you plan to practice till you're like 100.
Oh my.
Or close. I have a doctor in my office here in Omaha who he's in his 80s. He's 85 and he's an ENT still practicing. He's amazing. So you can do it. I'm rooting for you. But yes, tell us, Dr. Stroud, about where your practice is. Give us the details of how patients can get a hold of you and all that stuff.
Well, I really don't want to promote me and my practice, and it feels like saying that is promotion. So I don't want to be self-promoting. We're blessed with plenty of work to do, as you are, and as everybody is in this space. But sometimes just knowing one place can at least get your journey started, even if you don't end up with that place. I get calls a lot from people in far distant lands who say, can you give me some advice? This is the person that I've been referred to. Do you know anything about them? And a lot of times, people like us that are in the know, we can creep on them a little bit through social media and their website, and we can read between the lines and say, yeah, that's a good idea, or no, cancel that appointment. But I'm really blessed to be in practice with 2 other physicians and 6 certified nurse midwives and a bunch of nurse practitioners and some amazingly talented physician assistants. We're called the Fertility and Midwifery Care Center. Our website is myfmcc.com. I really think there's a lot of great information there that could just get you started on a journey to maybe finding a provider that hears you and sees you if you don't feel that way at the moment. We're on all the social media platforms. I try to host a podcast called All Things Women's Health, and try to get hormones on there as often as we can. We recently lost a physician, I don't mean to death, but to relocation. And so our schedule's a bit of a mess, so I'm way behind in All Things Women's Health, but we'll be catching up, I hope soon, with some great guests. So you can check that out if you like. We also operate a freestanding birth center called Holy Family Birth Center. And it's a beautiful facility. If there's a few inches that don't have a crucifix on the wall, I need to fix that because we try to cover every inch that we can. It is a beautiful place to have a baby. We like to say birth as it was intended, where we really honor the holiness of physiologic natural birth. And it is a beautiful, beautiful thing. That's FortWayneBirthCenter.com if you want to check that out. You might live too far away to think about using us for birth, but it might get you on a journey that helps you find a facility near you. So that would be helpful. We do a lot of telemedicine consultations, as I referenced. So we have an entire hormone optimization division where they do telemedicine visits and order labs and interpret those labs and can really help people get started. Also in the NAPRO fertility side for things like ovarian wedge resection and just primary fertility, both male and female. My partner, Dr. Jillian Stalling, and I do that a lot. We do a lot of telemedicine and are happy to try to help. Now, if you're super motivated and excited when you hear this and you call the office, I'm sorry to say that the parking lot is full at this restaurant, so please be patient with us. Grant us some space and some grace, but we'll do our best to get to you absolutely as soon as we can. But that's really more than you need to hear about me.
That was awesome. So thankful that we've been able to have this conversation with you. And I sure want to visit your practice. If I'm ever in the area, I will stop by. But this has been such a delight to talk to you. And maybe in the future, we can have you back on.
Well, I'll one-up you on that. Let's just agree here live with listeners that you'll come on our podcast, All Things Women's Health, and the 2 of you talk about your work. I think that would just be terrific. I'd love to have my audience hear your work.
Awesome. It's a deal.
Deal.
Fair enough. Yeah, God bless you and God bless your amazing work.
Thanks for listening to the Hormone Genius podcast. Please remember to share our podcast with your friends and family, and also follow us on social media. If you were not aware, we have a YouTube channel, so if you could like and subscribe to our YouTube channel to stay in the loop with all of our latest episodes, we would appreciate that. Thank you so much for your support. We are excited to journey alongside you as you discover the beauty and the genius of your hormones.